Welcome you all to this EGDRC special series to celebrate the World Diabetes Day month. Today's speaker is Dr. Saria Hassan. And briefly, Saria is an assistant professor in medicine at the Emory School of Medicine and also a faculty at the Department of Global Health at the Rollins School of Public Health. And Saria focuses on implementation sciences, particularly in regard to chronic diseases in humanitarian situations, whether it be climate change or earthquakes, wars, conflicts. So she's interested in the larger perspective of NCDs in people affected by underprivilege or by disturbances in the environment. Saria's background, she got her undergraduate degree from the MIT, went on to do her medicine at the Harvard School of Medicine, and then did her residency and fellowship at Yale in adult medicine and in pediatrics, and has come to Emory. So we are so happy to have her at Emory. And the topic today that she's going to present is something that is born out of an article that she led for the Lancet special issue on disparities in diabetes. So this paper, a lot of what Saria is going to present today, I imagine, is published in that paper. And again, Saria and Myra, after the seminar, I hope you would share the article through social media and other means so that people get to see it. It is a very well put together article highlighting disparities in diabetes prevalence, and management and outcomes, and ways to think about it and think of what you can do to reduce these disparities. With that, I'm going to hand you all over to Saria. Saria, it's yours now.
Thank you so much. Just checking that the people online can hear me okay. Sweet. Yeah, awesome. So thank you, Venkat, for that kind introduction. Thank you to EGDRC and especially Myra for putting all of this together. This is really a privilege to talk to you about a topic that I think is near and dear to all of our hearts. And so I'll really be summarizing, in addition to summarizing, putting a little bit of my own work and research into the summary to really think about what we described in the paper as a path forward as we think about managing disparities in diabetes. Okay, so this is really a huge collaborative effort, and this amazing group of friends and colleagues did a lot of work to put together this paper. And so I am really presenting on behalf of all of these amazing people and all of the combined work that went into this paper. No disclosures. So what I'm really hoping to do today, the next about 40 minutes or so, is summarize the main points of our published paper. The paper does attempt to look at the past decade now of disparities research in diabetes. I'll talk initially about the complexity of diabetes disparities, the multidisciplinary approach that we need to take to understand the complexity of diabetes disparities. And then I'll share a framework that we put together to help us understand the causes of diabetes disparities. And using that framework, we'll then put forth some recommendations as how we can move forward to try to achieve that. Start, let's kind of set the ground and make sure we're all on the same page in terms of definitions, right? And so first and foremost, race and ethnicity, we did use the Office of Management and Budget Standards, the OMB standards for the definitions of race and ethnicity. You will see that we have a lot of issues with these categorizations as we go through our conversation, and hopefully that point will become very clear by the end of our discussion. But this is traditionally how disparities have been looked at, and so the paper is framed using these definitions. The other definition that I think is really important for us to understand is the difference between equality and equity. So this diagram shows you that if you give people, a diverse group of people, the same bicycle, not all of them would be able to go from point A to point B. But if you really take in an equity lens and give people the type of bicycle that they need, that meets those specific needs, then everybody would be able to go from point A to point B. And so what we're going to be talking today about as we think about health disparities is really how can we achieve equity. This is not an equality issue, this is an equity issue. So now now that we've had kind of terminology, hopefully terminology in terms of race and ethnicity, and terminology now in terms of equity and health equity, and that's what we're trying to achieve, let's turn to diabetes. But I want to start with a global perspective, mainly because the majority of people in this room come from a global health background or are doing a lot of global health. And as much as we will be focusing on the US, I think it is important for us to all remember that this is a global problem. Not only is this a global problem, but a large proportion of the mortality that we see related to diabetes exists in low and middle income countries. So that being said, though, and projecting forward, we will continue to see a rise in the burden of diabetes in low and middle income countries. But that being said, a lot of the time, I always say, global health starts at home. And so as much as we talk about global health in an international setting, global health is really in our backyard. And sure enough, the United States is one of the top 10 countries when we think about burden of diabetes. So not only are we number 4, we are also very high in terms of expenditure. So that pink bar is health-related expenditure due to diabetes, regarding diabetes, and the yellow bars are prevalence. You can see we surpass everybody regardless of prevalence. But it's really in this context that we want to talk about diabetes in the United States. Understanding there's a global burden, but what can we learn in our backyard? What are the problems in our backyard? Let's address those as we also try to tackle the global topic. So this is what we're diving into today. The 37.3 million people in the United States, that's 1 in 10 in the US who have diabetes. But that number, there is so much packed into that number, and that's what I'm going to try to unpack as we think about disparities in diabetes. And as we think about that, I'm going to look at 3 levels. We're going to look at geographic inequity related to diabetes. We are going to look at within race differences related to diabetes. And we're going to look at disparities among the youth. This is really the new lens that we're bringing in this paper to think about disparities. It is not just a Black, Hispanic, white issue. There is so much more complexity in diabetes disparities, and that's what we're trying to tease out. So let's start with geographic inequity. So this map shows at the county level the prevalence of diabetes. The darker the blue or the purple, the larger the burden of diabetes. So you can clearly see just from this map the level of diversity, the level of differences in the amount of diabetes at the county level that is an expression of geographic inequity. But geographic inequities gets us to realize that the US is not just the mainland US. Right? When we think about disparities within the United States, we cannot forget that there are outlying islands, the US territories, that suffer a disproportionate burden of diabetes. And when we think about diabetes disparity in the US, we cannot forget that there are this disproportionate burden in the US territories. I do a lot of work in Puerto Rico and the Virgin Islands, but you can see also that the Pacific Islands in particular have a very high burden. So this is the traditional outlook of diabetes disparities: Black, Hispanic, Asian, white, and the US average. Native American population is actually not even on this graph because they're off the grid, and I'll talk about that in a moment. But what you can clearly see here, that traditionally, as I think we've all kind of talked about and addressed in many other instances and many other settings, that there is a higher burden of diabetes among the Black, Hispanic, and Asian population compared to the white, non-Hispanic population. And let me talk a little bit about the Native American population, because undoubtedly they suffer from the highest burden of diabetes today, and the projected burden of diabetes moving forward is also very high. But even within the Native American population, there is disparities. And this is looking at prevalence of diabetes across the different counties in the US and different regions within the US. And so there's also kind of this interplay now between the geographic location as well as the social determinants of health that are part of the reason the Native Americans have such a high level of diabetes. And also to show that there's a lot of these regions that have much higher prevalences of diabetes than the US average, which is listed with that red line. So now let's start to think about the intersection between the geographic inequity and the racial inequity. So these are very interesting maps that look at diabetes-related complications. And this is mainly in Florida. And so the blue is showing you the burden of amputations due to diabetes. The darker the blue, the more amputations due to diabetes. Now, the next graph that's right next to it, the next map, is showing you the prevalence of Black non-Hispanic populations in Florida. And so what you can clearly start to see is the overlap. The same regions that have the highest rates of amputation due to diabetes are the same regions that have the highest prevalence of Black non-Hispanics. And so what we're starting to see is that, is there an overlay between where people live and the complications and the burden of diabetes they suffer? So this is really one of the most stunning examples of structural racism, right? There's something here geographically with how and where people are located that is now getting us to see these maps that are so coinciding and so overlapping. But this is not something that is new to us today, right? This goes back historically many years. And so it's really wedded in these racist policies that date back to the 1830s with the Indian Removal Act that led to the relocation of Native Americans from the land, agriculture, and the ways of life that they knew best. That in many ways were the ways of life that prevented them from developing many of these cardiometabolic conditions. In the same way, this is wedded in the redlining policies of the 1930s, where maps that are similar to the maps you see on the right here were literally labeled in red. Those areas that designated majority Black neighborhoods that were deemed very risky and actively discouraged people from investing in those neighborhoods, giving loans to people in those neighborhoods. And so it's no surprise that those are the same neighborhoods that today have the highest burden of diabetes, have the highest burden of diabetes-related complications. And so this is part of that structural racism problem that you see is really the anchor of the framework that we're going to promote. And I just want to say that this structural racism does not only, portend for diabetes as it does for other chronic conditions. It is something that we are realizing more and more in the face of climate change. And as we realize now the impact of climate change on diabetes, on asthma, on any chronic condition that you are working on, climate change is affecting. And so if we already have underlying disparities in those chronic conditions, and we now start to see that climate change is also not affecting everyone equally, the outcome of that is only worsening disparities as a result of climate change. So this figure depicts that. So the images, so these are all different states in the United States over here. And these are the areas that were graded A in those 1930 redlining policies, right? Those are the best neighborhoods. You need to go invest in those neighborhoods. And then D are the hazardous neighborhoods. Those neighborhoods in red, majority Black neighborhoods, right? And then what they did was look at the change in temperature in the hot season compared to the average. So blue here is the city average temperature. And you can see that the best neighborhoods are generally a lot cooler, negative, minus. They're a lot cooler than the average. But your red line neighborhoods are much hotter. So this is why when we think about urban heat island effect, when we look at hot Atlanta and pieces of Atlanta that are significantly more hot, it is the west and southwest of Atlanta, which are historically red line neighborhoods. And so I think this is another striking realization to what Ban Ki-moon said. Climate change affects us all, but it does not affect us all equally. Those who are the least able to cope are being hit the hardest. And so this is from the main point of the conversation, but it's also for us to realize that as we talk about disparities, this is where we are now. There are going to be things that are going to worsen those disparities unless we start to act. And so I talked about the structural racism that's wedded in a lot of these racist policies of the past. And with that, we can start to understand now that these numbers are not a surprise, right? These traditional disparities that we look at between Black, non-Hispanic, white, and American Indian are not a surprise when things are wedded in that structural racism. But I think one thing that we've tried to do in the paper is say that when we say Black, there's so much in that. There's so much nuance in that we lose when we aggregate groups in that way. And that we really, as a public health entity, as a health professional entity, need to start about thinking about the disaggregation of race. So the next few slides will give you an example of that. So this is a paper by and colleagues that looked at looking at differences between Black Americans who are U.S. born versus foreign, and asking about the prevalence of diabetes within these populations, and you can clearly see there's a difference. And so when we group Blacks as one, we lose that nuance that is going to help us determine how to help people the best. Similar to the Hispanic population. probably most classically the Hispanic population. You can see the clear difference in prevalence rates here between South Americans and Puerto Ricans, right? But when we talk about Hispanic Americans, we lose that nuance unless we are starting to think about disaggregation of race. Similarly, a population that many of you in this room work with is the Asian Indian population. But again, if we just say Asian, it's 9.2%. But if you start to clearly see the nuance when you start to break down and disaggregate that racial ethnic group. So this is younger folks. So this is 18 years and older. And we can similarly do it for adults which are older, 45 to 84 years old. And this also includes the Native Hawaiians and Pacific Islanders as well. But really the point of this is to say that if we do not disaggregate race, we are losing so much nuance when we think about disparities. And by doing that, then we are actually disadvantaging the people with the most. The other point that we try to make in the paper is that we talk a lot about type 2 diabetes in adults. But the reality of today is that there is a striking shift in the age at which we are seeing type 2 diabetes. And type 2 diabetes is occurring earlier and earlier. And most worrying is that that type 2 diabetes is occurring earlier and earlier in our minoritized populations. And so if we're at baseline at the age of 15 seeing disparities, what is that going to do to disparities in adulthood? So this is data from the SEARCH study. You can clearly see that this is now incidence of type 2 diabetes that was projected out, and this is kind of oldish data now, but you can clearly see that we had a much higher incidence of type 2 diabetes in the American Indian population than the white population. So this is not just an adult problem. When we start to address this, we really need to think about a lifespan approach. Similarly, this graphic from a similar paper around the SEARCH study got us to start to think about what it looks like today if we now break it down by sex as well. So looking at females and males. So this is the age 10 to 14. Again, this is now prevalence. Before we looked at incidence, this is now prevalence of type 2 diabetes. This is 10 to 14 and 15 to 19. I'm just going to focus on this 15 to 19 panel. The different dots here are year. So this is 2001, 2009, and 2017. You can see how everything is going up, right? There is a trend, especially in the Hispanic, the Asian American, the Asian Pacific Islander, and the American Indian, that the rates in 2017, orange dot, is showing a much higher prevalence of type 2 diabetes in our children than there was in the past. In addition to that, we can clearly see that the orange dots for the American Indians and the Black and the Hispanics are much further on the right. So again, just making the point that not only is incidence of type 2 diabetes higher among our youth, the prevalence of type 2 diabetes today is higher in our youth. And so what I hope we've done a little bit is say, it's kind of complicated. It's not just a black-white problem. There's so much more nuance as we think about the burden of diabetes and diabetes-related complications today. But before I move on to talk about a framework to think about the causes of these disparities, I just want to briefly discuss the important role of pathophysiology. Probably because a lot of you in this room think a lot about pathophysiology related to diabetes. But before I do that, I just want to be clear that biologic differences are not a cause of disparities and health inequities. So biologic differences are not a cause of health disparities and health inequities. And I think we have to be very careful as we talk about pathophysiology to say we are talking about pathophysiology, we are talking about the role of polygenetic risk scores, which are a big thing now and thinking about diabetes risk. But as we think about that, it does not mean that we kind of put to the side the issues around structural racism. But they are yet important, and they're important because they allow us to start to understand how to better detect diabetes earlier, and they help us realize how can we better manage diabetes. So that's really the role of thinking about pathophysiology. So this paper by Dr. Gujral and colleagues, some I think in this room, really started to get us to think about BMI. One of the hottest topics I think around is BMI. Why do you only screen if the BMI is greater than a certain number? And how many people are you really missing if you screen out of only a BMI at a certain number? So this really made the point that we really need to think very carefully about BMI as our marker for screening for diabetes. So this paper looked at data from 2 cohort studies that were focused on Asian Indians in the US and in India. They looked at the prevalence of diabetes by BMI, comparing Asian Indians to white Americans. And what you can see here, so you're going to be looking at those bar graphs that are underweight and normal weight that I have circled. And you can see that the prevalence of diabetes for Asian Indians among those underweight or normal weight is much higher than among whites. That's a lot of people we are missing if we are using solely BMI to screen for diabetes. In addition to that, people have started to say there is so much complexity in diabetes. Type 2 diabetes does not all look the same. And if we start to understand that nuance, and part of it is due to polygenetics that help us understand what types of diabetes might be better managed by one treatment versus another. But we really need to start to really think a little bit outside of the box and not treat all of type 2 diabetes as one. So let's think about diabetes phenotypes. Instead of really kind of classically saying, diabetes in Black American, diabetes in Hispanic American, let's think about diabetes phenotypes. What does that really suggest for us when we think about their risk for developing cardiometabolic conditions, and also importantly, their treatment mechanisms? So this is one paper that was looking at diabetes phenotypes and cardiovascular outcomes, and thought that, this is one proposition for how we better think about diabetes phenotypes. That it's autoimmune. These are your younger people, really young people who might be a little bit more lean, but they're not type 1 diabetics. Where do they fit in? That's one category of people. There's your mild obese phenotype. There's the age-related phenotype. Those people with type 2 diabetes that develop diabetes much later in life. Insulin-related phenotypes is really important because we think a lot about those who have a severe insulin deficiency and severe insulin resistance. We think about that because your treatment decisions and treatment mechanisms for those two types is very different. Another paper by folks from the Masala study looked at data from the Masala and the MESA study. It was a really interesting way to think about diabetes phenotypes, looking at different racial and ethnic groups. And can you now look at different racial and ethnic groups, but instead of focusing on race and ethnicity, focus on phenotype? And then what can we find out? And so these were 5 categories that they came up with that were related more on phenotype and less of a focus on race and ethnicity. And so hopefully what I've done is given you a little bit of the lay of the land of not only the complexity, but also the nuance that's really in our discussions around diabetes disparities. So with that, let me hope to offer you a framework for us to think about as we move forward. So this framework we adapted actually from Dr. Agural, who has 2 other papers in this Lancet series, which I do urge you to read. They're amazing. One of them is global health focused, so might be of interest to many in this room. We adapted her framework a little bit, but the basis of this framework is that, again, much of the disparity that we see is wedded in structural basis. And so we really start with that. But as we think about that, it really bleeds into the domains of health behavior and social norms, into the issue of access to health, to high quality healthcare, into economic development and public awareness. So, and in the paper, you'll see that we discuss how these domains differentially exert their influence at multiple levels, at the individual level, the interpersonal level, community and societal levels, and really doing this across the lifespan. And that's what we're trying to show through this one image of our framework. When we think about those levels are really wedded in the socio-ecological model, right? And that many of you here have used the social ecological model and allows us to really think about interventions when we think about hopefully solutions to this problem, and the fact that we really need a multi-level approach. And that's part of what the socio-ecological model is bringing to us today. So what we did, is when I get in the room where we spent many a day thinking about this table, is try to say, okay, so we have the 5 domains that we have in our framework: structural racism, economic determinants, public awareness, health behaviors, and access to high quality care. And then we have levels of those issues, so levels from the individual to the societal level. And then how can we draw from the data now to populate this table, to think about what are the causes of health disparities in diabetes that are at the individual level, that are at the interpersonal level, and that might span some of these important domains. So this is what the table looks like. The point is not to have you read it now on the screen. Hopefully you will go to the paper and you will read it there. But really to show you the hopefully a rich kind of place to go to think about causes of health disparities in a more structured way. You will see that there's a lot of overlap in this table. And I think that's what, at some point, we just said that's okay, because we were trying to only fit things in certain boxes, and then we said, you know what, overlap is okay. Overlap is the reality of what we see. That things like structural racism are going to bleed into economic determinants. It's going to bleed into so many of the other domains that it's okay if there's a little bit of overlap and repetition. So I obviously don't have time to go through all of these, but I just want to maybe kind of point out a few key points from each of these domains. And so I'll start with structural racism because, again, it's at the top of our framework. That's really how everything is kind of wedded as we think about structural racism. And what I've tried to do as I show you these slides is go from the individual level to the societal level. So you'll see these kind of factors that we've kind of pulled from the literature as causes here within structural racism. And you'll see some that are very racism, discrimination, chronic stress, poor sleep, all things at the individual level, obviously. Heat, air pollution, environmental toxins, food deserts, walkability, and climate-induced disasters. So these are all things that we know now the literature is telling us. They are related to structural racism, and they are a cause of health-related disparities. And I just want to point out a few. I don't know if there are any environmental health folks in here, but there is growing literature now around the role of environmental toxins and endocrine disrupting chemicals for diabetes risk. And so this is a growing area of study, and primarily because exposure to these toxins is not the same for everyone. And there's a lot of people, both at the School of Public Health and at the college, who are really looking in depth around how this is contributing to our health disparities. I do a lot of work in the climate-induced disaster space, right? Where we have shown a lot that climate-induced disasters will worsen disparities around non-communicable diseases generally, diabetes being included as part of that. And I'm happy to say that we have a book chapter coming out with Dr. Dabney Evans, where we really provide another framework to think about how climate-induced disasters will worsen health disparities in chronic diseases, including diabetes. So let's turn to economic development. And I think economic development is probably the one that we all go to when we think about health disparities, right? Food insecurity, housing insecurity, income, education, access to insurance. A lot of that has to do with the individual level economic development, neighborhood level economic development, and now you start to see how the structural racism kind of will bleed into that. But in addition to that, we have to think about public awareness. And public awareness really has many, many different domains when you look at the paper. There's so many different aspects from how we can raise diabetes self-management knowledge that will clearly help people self-manage the chronic disease, to people realizing that, you know what, climate change is worsening your diabetes, and how is that actually happening? Because if you realize that, then you start to pay attention, not only from a mitigation standpoint and trying to reduce, of course, our contributions to climate change, but also from an awareness that when it is hot, what does that do to my diabetes? How does air pollution affect my diabetes? People are not really cognizant of that. With the advent of climate change, we do need to raise awareness around it. So let me give you a few examples of how we're doing that here in Atlanta. This is an Environmental Protection Agency grant that we have. We're now in our second year. That's working with those same communities in the west and southwest of Atlanta that I said were the red line communities of Atlanta. When it rained on September 16th, those areas were completely flooded. There were other pockets of Atlanta that were flooded, but not to the same degree. And they see this every year, multiple times a year. So there's flooding. When there's a storm, they're the ones who lose power. When there's heat, they have the urban heat island effect, and they're most affected. So people in these communities need to not only realize how climate change is affecting their diabetes and their other chronic diseases, but they need to figure out how do we strengthen their resilience. And so that's what this project is doing, both, again, addressing that public awareness, but trying to find a solution. So then we get to health behavior. And this is what a lot of people here are trying to really work on, is how do we change people's behavior at an individual level so that we can reduce diabetes disparities, but how can we do that more at a community level, at a systems level as well? And so these are some of the things that you might think about as we think about diabetes disparities at those different levels. One thing I do want to mention, and I think this is a critical point as we think about health behavior, is what it means for immigrant populations and for refugee populations. Because I think a lot of times, and I know some people do work with immigrant groups as well, that there are multiple other barriers that you see listed here. So not only is there limited English proficiency, there are cultural barriers to actually thinking about diabetes management, and there's acculturation that we have to think about. There's a lot of complexity in there. And so one example, and again, trying to give you examples of how we're trying to think about health behavior for these different groups. This is a project that we started in Clarkston. which is most diverse square mile in all of the United States, so a huge refugee population in Clarkston, and thinking about how do we bring tailored and multidisciplinary diabetes management now to these communities, right? And we're very thankful to the GCDTR to give us a grant where we'll now be thinking about adapting the diabetes self-management program for refugee populations in the United States, starting with the Burmese population. We saw amazing Burmese interpreters on the prior picture, and then hopefully expanding that to other populations as well. And there's access to high quality health. And for the physicians in the room, this is something we think about all the time. Not only because we hear the complaints from our patients who have experienced implicit bias, explicit bias as part of their healthcare experience, which leads them to not trust the health system, which leads them to not come to the doctor, which leads them to the amputation that we talked about previously. But there are so many levels of access to high quality care. And so it's not only the cost of care, it's mental health services. So the relationship between mental health and diabetes is huge. And I know many of you worked on the independent study, which clearly showed that as a relationship, right? If you fix mental health, you will improve diabetes care. But also subspecialty care access. So when we think about islands of specialty care and islands of access to endocrinologists, not everybody has the same access to that subspecialty. And of course, there's the differential access to medication. And this was really borne out by the look of GLP-1s, right? Access to GLP-1s, which are like a hot topic now. GLP-1s, well, now people are going to the hospital because of fake GLP-1s, but it's really important for us to think about who gets access to these new medication when they come out, right? And so this paper that came out, I think some of you might have been at TBSCN, who's done a lot of work around pharmacoequity, which is a new term now that's out there. It's how do we think about equitable access to new pharmaceuticals? So this is a graph that is showing accumulated rates of GLP-1 use among a cohort of patients with type 2 diabetes by race and ethnicity. And so the top graphic here is your white population, so you can clearly see over time rising rates, but the striking disparity between white and Asian populations. Right? So the next question we ask is the why and how do we fix that? But a lot of it can come from that same framework where we think about domains and we think about different levels across the socioeconomic model, because this is a problem we need to fix if we're going to get to that health equity issue. So hopefully we've given now a nice kind of setting of what the framework is trying to give us, what the framework is trying to tell us around the different domains that might be contributing to disparities in diabetes, that we need to think about it at different levels across that socio-ecological model, and that we need to think about it across the lifespan. But now what do we do about it? So that's really, I think, probably the crux of the paper and the end of the paper. But really, hopefully, the message that maybe we'll have some time to discuss. So we made recommendations for a path forward. And we tried to group our recommendations to different groups of people. And the first we started off with were researchers, which I think many of you in this room fall into that category. So based on what we know about those domains that are influencing health disparities in diabetes, what do we need to consider as we are designing our projects, or as we are considering projects that are already ongoing and their impact on health equity? And so first is the community-based participatory research. So I should have really said as I started this conversation that I come to this conversation, a very difficult conversation, a very complex issue, from a position of privilege in many ways. Also as an immigrant to this country and not from a Native perspective. And so we have to realize that it's people within the community who have that lived experience that in many ways have the best solutions. And that's really, if anything, the biggest reason to do community-based participatory research, because in many ways the community knows what's best. And so really pushing for us to do more with the community for the community. The other thing is a lot of us will focus on just adults, just kids, or just pregnant women. But really, how do we start to think about a lifespan approach, right? How do we work together now as people working on kids and adults and try to think about interventions that might actually impact all levels? And then I hope I've made the point clear that environmental justice and climate justice really need to be thought of regardless of what field of work you are in. It is impacting your work, if not today, tomorrow, but I'm sure even today. And I think we really need to push forward the agenda of trying to integrate environmental justice and climate justice into all of our work. I'm happy to say Dr. Yang Liu here in environmental health has got a large P20 grant that will start a climate center here, which is very exciting because they'll be focusing on heat initially, but hopefully eventually be expanding to other areas as well. And of course, as an implementation scientist, I would be amiss to say that you should not all be doing implementation science research at some level. I think part of the challenge that we always have is we think about implementation problems too late. And so if we start to think about intervention work, but really start to think about putting into place the mechanisms through which we can really understand how and why interventions fail or succeed. And if we do that early on, then we can really start thinking early on around how is this intervention worsening health equity, or how is this intervention improving health equity? The other point of conversation that we had in the paper is around funders of research. I'm not sure if any of you here are funders of research, but I do think it's important for people who fund research to be dictating what they will allow in the plan, especially when it comes to health equity. And so there are examples of proposals, calls for proposals that have required a health equity plan for researchers to think carefully around whether or not their work will be promoting health equity or not. And clearly, if it's not, then you need to rethink your work. But that's part of the impetus behind this idea around a health equity plan. The other thing is to really push for us to do more multi-level and multidisciplinary research. You saw the complexity of this problem. You saw that really a one tiered approach is not going to solve the problem of diabetes health disparities. I think really understanding that if we promote diversity in our early stage investigators, we can try to promote more work in this space. So another, hopefully, pitch for funders. And then our practitioners. And I think for those of you on the front line of actually treating and managing diabetes, these are things we need to continue to talk about, continue to address, and continue to face up front, because I think the amount of discrimination and either implicit or explicit bias that's happening in our healthcare system is now very, very overt and obvious, and we really need to be moving through conversation to be able to address it. And so these are some of the recommendations we have there. And then finally, to policymakers, right? And you saw that much of the issues that we have around structural racism are really wedded in policies. They're in policy. And if perhaps those policies had not taken place, we could be in a very different place then. But importantly is for policymakers to not only realize that those policies are part of the problem, is to start to think about how do we reverse them. How do we start to now put into policies that really reverse from the 1930s and even before that, the implications of redlining and the impact on the Native American population. And so in conclusion, I hope I've discussed really the complexity of diabetes disparities. We talked about the geographic level of inequity. We talked about how geographic level inequity overlays many of the disparities at a racial ethnic level, and we saw those names. We talked about how we need to now not only think about disparities among our adults when we talk about type 2 diabetes. This is starting very early, and it really urges us to take more of that lifespan approach. That when we think about race and ethnicity, we need to think about disaggregating race. That there is so much complexity and nuance that we need to be able to tease out for us to devise interventions that are more appropriate for populations. In addition to that, hopefully we have set out a framework that allows us to think in a more structured way about the causes of diabetes disparities through these 5 domains, and using the socio-ecological model, obviously, at different levels. And hopefully we've also made a call for different groups, and I'm sure you all fit into at least one of these groups, if not multiple of them. That really we need to start thinking about addressing diabetes disparities regarding these domains, regarding the numbers that we saw, so that we can eventually really try to move towards health equity in diabetes. And so with that, I will end. Thank you for your time, and hopefully you have left a little more 15 minutes for the discussion.
We have a question in the chat that says, what does environmental justice and climate justice look like in relation to economic justice?
Ooh, it's a great question. A very, very heated question. So you are right that with economic justice, we may be able to overcome many of the environmental and climate injustices in the future. But I think the problem is the urgency of now. that right now, I'm looking at you, but I know you didn't ask the question. But the urgency of now is that as we work a lot on economic justice and trying to improve the economic potential of our marginalized populations, that will take time. It's not that we don't need to do that. And I do think, and we need to invest more in these communities so we give them more economic opportunities. But at the same time, the environmental injustices of today are happening now, and they are affecting people's health now. So if that means the EPA needs to pour in more money to clean up the soil in our lead-infested areas in the west and southwest of Atlanta, that needs to happen now, not 5 years from now when we develop economic mobility for people. The same with climate injustice, right? These disasters, these floods, these droughts, these heat effects, they're happening now and they're affecting our health now. So I think it is a conversation where they're all linked, they are all interlinked. And that's part of that diagram and the complexity of how all those things interrelate. That as we push for economic justice, we will be also improving and addressing environmental justice and climate justice. But I think the bigger thing is realizing the urgency of now, that we cannot do one and not the other. That it really needs to be a multi-pronged approach because climate change is here and the environmental determinants of health are here. Hopefully that answers the question.
Yeah, thank you so much for this presentation. It's super exciting work and I really enjoyed hearing everything, and I will make sure to read the paper, one of the 3 papers of that series. I kind of have 2 questions which are somewhat related. And as a disclaimer, I'm a naive European, so I might have different views on these things, but always when I hear conversations about equity in healthcare in the US, then I always think like, okay, yeah, but this healthcare system is not designed for equity. Like there is no political consensus for equity. It's not made that like low income populations can have the same health outcomes as more high income populations. So like, I guess the first question is just like, how did you work with that tension, knowing that there's this political landscape around it? And then the second more practical question is like, in the synthesis of all the literature that went into this project, how did you think about causality? Because there's like a lot of overlap between different issues like race, socioeconomic status, education, which is very hard to tell apart, but will have very different implications in terms of the actions you take.
Yeah, both excellent questions. So first on the politics and our healthcare system, and it's not built for equity. I think those are all very, very true statements. I think that unfortunately, and again, I'm also coming in, I came into the system, but as a practitioner even, I see it on a daily basis in terms of what medication I'm able to prescribe for my patient, what medication, am I able to get them continuous glucose monitor, which I think everybody in the world should have. Right, so there are nuances that we face as practitioners on a day-to-day basis that makes us realize that the system is not built for that. Yes, that is a political debate. We saw all of the debate around Obamacare and whatnot, and what that could bring us, and potential had to bring us, and what it has brought us, and many good as well. But not the answer I have. Right? I mean, I think as much as we advocate for our patients, as much as we can, at some level, those are discussions that are at a higher level than as much as maybe I would advocate for universal healthcare coverage. I can't. So, or we cannot make that change. But it's a great point. Our system is definitely not built for equity. Given that, we need to figure out ways of trying to advocate for our patients and improve their ability to access care within the broken system. The other question that you had was also very good. Thank you.
Think around causality.
Causality, yes. I think it's very difficult. It is very, I mean, I think the economic justice, environmental justice, health justice is another perfect example. Everything is so interlinked, which is why I think when we were putting together the table, it was so challenging because there is so much. But if any, and so I don't think we can really speak directly to causality. You'll see that a lot of the papers that we quote are association studies, right? I mean, it's very difficult to kind of talk about causality per se, but there's enough in there to say that the combination of these things is causing health disparities. Which one more than the other, and which one is causing one that's causing the other, I think is harder to tease out. From an implementation science perspective, though, it does mean as we think about our interventions, multi-level approaches are needed. This is not one thing is going to fix it. Absolutely not. And hopefully the complexity of this shows. Great question.
So I actually had a follow-up because I was thinking the same thing that you were saying about multi-level. And what comes to my mind is that it's hard to think about when you are intervening at, let's say, individual and community and or policy levels, how do you evaluate that? So the world of natural experiments has had the hardest time even just evaluating the higher level influences of a state or a city, where the findings often are very blunt because they are so-called affecting the whole population, but really probably having the biggest effects on subgroups. And then it has the whole problem of observational data being a big issue. So maybe this is a space, or maybe you have an answer, maybe this is a space for an innovation in methods that do multi-level work.
Yeah. I think that's a great point. It's a great thought. I think the evaluation piece is really, really hard, especially when we do need it at so many different levels, and especially when one level is that, like you said, that systems level approach. So I echo that for the up and coming implementation scientists to think about evaluation methods for this, for sure. I will say in the climate world, we struggle with it a lot, just because it is really hard to kind of tease out climate effects from everything else. In the climate disaster world, I struggle with it even more because we never want to wait for a disaster to show that something works. So I do think there's a lot of space in this realm to think about it. So it's very
If I can just follow up, this is maybe the one area where differences in states, for example, where some states are, whether you call it progressive or whatever, make changes quickly and others don't. That variation allows you to actually see if somebody's doing something, does it actually make a difference?
absolutely.
Kind of comments this question. Thank you for this great kind of presentation. It was nice to dig back to the table again. I was actually thinking, as we're having this conversation and thinking about your efforts to kind of share the findings from this paper, how oftentimes we are sharing this in a room of like-minded people who agree with everything that we are presenting. And I was wondering if you have thought, or we as a group could think about how we disseminate this sort of thing to a broader audience. And I'll tell you, I'm reminded of this because Saria got approached by a very conservative, right-leaning media company who asked them very targeted questions about how you can say that, for example, I don't remember all of it, but something about like how you can say that redlining causes diabetes, right?
Yeah.
And so it's like, do we engage in this conversation or not? And if we choose not to engage, which I understand for many reasons we choose not to engage, are we just staying in our own echo chamber? And like, how do we think about broader dissemination beyond the Lancet audience?
Ben, were you gonna say something?
Oh, actually, I was loving the conversation. So let you say, then I've got a couple of comments too, or thoughts to share.
I mean, all I'm gonna say is I completely agree. I think it's such an important point. And how do we do that in a safe space? Right? I think that's always the challenge, and that one example is a perfect example. Is that that's a group that we want to engage, but clearly not willing to do that in a safe space.
Right, not in that particular.
Exactly, yeah. But I do think we need to, I think as a group, really need to challenge ourselves. We need to think about how do we do that?
Well, I'll just share one other example. When we started doing a lot of community outreach in the South Asian community here in Atlanta, and we shared some of this data around South Asians having, some papers quote, like 3 times the rate of diabetes, prevalence of diabetes as whites. Literally, one of the community leaders said, how come we're hearing this for the first time? You know, and so, I mean, I think there are safe spaces to think about that engagement. But I think we also have to challenge ourselves to go out there and do that, which is way out of our comfort zones.
Yeah, but it's important. That's a great point.
Yeah, Saria, this is a wonderful presentation, and I'm enjoying the discussion. I mean, based on the last 2 or 3 questions, I have a couple of thoughts. I think, firstly, we should get away from this notion of causality in this kind of work. It's a trap. You're not going to show causality like Moa alluded to, and economic policies are made. Nobody goes around establishing causality. What you're basically saying is there is a set of factors and a set of patterns which seems to increase the probability of adverse outcomes, and by changing that, the demonstration is we can change the outcomes. I don't think you need to show mechanistic connections. So I think that is, in a way, we have got into this trap of reductionism by focusing overtly on causality. I don't think we should. I think because it's an impossible game. That's number one. So I think we should reframe the scientific conversation away from the notion of causality, more into the level of impact. And yes, we know, if we did all this, things change. We can play around sensitivity. You can reduce a little bit of that, increase a little bit of that, and show that, what kind of interventions work, what don't work, etc. So we need to reduce the level of kind of scientific inference in that area. Secondly, coming back to what Megha said, it's absolutely correct. We in this community, we shy away, we talk to our own echo chambers, and we shy away from people that want to argue with us. We need to take this out to, at least, you don't need to go to extreme groups, but people who are skeptical of our work, and we need to engage. I mean, maybe we need forums that cause that kind of tension, and creativity comes out of it. And also we need to step out of and disseminate our results much more aggressively, including to people who disagree with us. I think that's number two that we have to do. And thirdly, I think, based on the huge body of work we have constructed, there is actually scope for some sort of a major initiative, like through the common fund mechanism, etc., both to develop some of the methodologies to study this problem and to advance some of these areas. As you were presenting, your first part of your talk made me think, equity equals precision medicine. That's what you're saying. Essentially, that's all you're saying. You're saying, if you have to deliver equity, customize your intervention to that person and their background. That is precision medicine. So I think rather than fighting precision medicine, we should co-opt them. So I think those are some of the thoughts that I have in my head.
Yeah, I mean, thank you, Venkat. And I think that the last point of precision medicine, I just want to echo that. I didn't include the slides on polygenic risk scores and the role of things like that. But if we are able to adopt things like that with an equity lens, I think there's a huge role for precision medicine. Absolutely. Thank you. Suchi.
I was gonna follow on to that and say, as you were sitting here talking about this, and you put up that slide, which is like looking at, of course, the lifespan as components as researchers, we even have to still just talk to people amongst us here. The outside is really important, but take a health system. Which health system is unifying the lifespan? Your children's hospital is physically at a separate place. Your women's service line is completely separate. Your endocrine folks are different. I have to fight to get them into there. They have to fight to get into me. I mean, we are dismantled amongst ourselves as providers. And if we don't take care of that first, how do we even go outside of it? So, I mean, this needs to go as they're creating service lines now in the AHC system. How do we create that here? Because for us to look at the lifespan, it's hard when we ourselves are fragmented within our own fundamental healthcare system. And therefore, I agree we have to go outside, but it just was striking me like we break everything apart. I mean, peds is peds, adult is adult. And then within adult, as you've said, we're all apart. And so I think as we're looking at precision medicine and care, it's almost like we need a paradigm shift on how healthcare is set up in hospital systems so that we have more equity and we're not completely divided amongst this particular service line, that particular service line, and then all fighting for the same pot to try to make this work,
Well said, Suchi, absolutely. I don't have, yes, I guess.
We need to go to AHC. We need to go. No.
Let's go to the C-suite.
Let's go to the C-suite.
Just because I'm curious, you were saying about things that cause like disparities in prevalence and incidence. And I was thinking about if there's something about like gender identity and sexuality, that maybe can also be like a factor in disability. But I think there's a lack of studies with this population, so I don't think that we have information enough for you to discuss it,
Yeah.
but it's just a point that I.
Thank you so much, and I think it's something we did not touch on in the paper, one for the lack of data, like you said. But we do know that there are significant health disparities in Philippines, for sure, among their populations. Yes, it's a push for more research, I think, and using that equity lens and perhaps a framework like this to understand ultimately how can we address it. But thank you for bringing this.
Amazing presentation. I really enjoyed it. Quick question on the phenotypes. I think that was a very interesting approach. I'm wondering about your thoughts on, are we at a point where the treatment guidelines can be tailored to phenotypes?
I think we're almost there. I mean, I know that we think about it clinically as clinicians. When we see someone who's extremely insulin resistant, we start to think about, okay, what does that mean for oral agents that I might use? What does that mean for GLPs that I might use? And then similarly for extremely insulin sensitive people. And so I do think clinically we've started to look at that, but we're not labeling it at phenotype, and we're not teaching those coming up to think about diabetes. So I'm hoping that some of these papers that are coming out are going to cause a paradigm shift, because I really do think from understanding both their risk for developing cardiovascular disease in the future, but also from the realm of understanding how we can better manage, I do think we need to go there. So we're starting, but not in a formalized way, I don't think. I don't know if, yeah, not in a formalized way, I've seen, but it's a.
If you go see Dr. Hassan, she's starting.
And
Yeah, well, and the other thing I would just say is some of these phenotypes, when they're incorporating something like insulin use into the phenotype, that becomes, to me, it's a challenge to think about that, because that again goes back to what has the management been to date to get them to insulin. You know, I think there's wide disparities in when someone requires or how much insulin they require. So I think we just need to be careful to recognize that their practice variation is not just practice variation. You've made a great case for showing that there are disparities that can drive practice variation. And then if you use that to then define a phenotype in a certain way, it kind of gets embedded into there. So, you know, we need to level the playing field first there before we
No,
which is the good work that needs to be done in phenotype.
absolutely. No, it's a really important point. And so when we think about insulin sensitivity, it's hard when people have limited access to insulin, right? Really, are we really testing their insulin sensitivity that way? But I do think when we think about some of these other agents and when to use them and why to use them, you know, we're going to need to make sure there's equitable access to all of them before we start to use phenotypes to determine whether or not it's a very. But I'm hoping we move that way as long as we fix the access issue at the same time.